Coming full screen. Good evening to everyone and welcome to today's session. Barry Allen, is the voice loud and clear? Barry Allen, Ravi Kumar, Priyanka, Prajakta, Sweetie, Shalini and many more who are all online. Welcome to Chai Pe Charcha with Dr. Murali Bharadwaj on this wonderful evening. Can you please punch whether the voice is loud and clear? Continuing our discussion on the NEETPG question bank in the last 15 years, the next topic of interest, the most high yield topic, frequently asked topic, is all about seizures. If 8 questions come in neurology without a question on seizures, there is no question paper, is what you need to remember. That's good. Now, what is the treatment of choice of the generalized tonic-clonic seizures that you see in pregnancy? Lamotrigine is considered to be a safe drug. Let's quickly run through the seizures. What are simple partial seizures? What is the meaning of that? Simple means there is no loss of consciousness. Partial because they are arising from one single focus in the brain. And typically the seizures will be skipping from one part of the body to the other, which is called a Jacksonian march, is what you need to remember. The simple partial seizures, they involve one side of the brain, they last for about 20 to 60 seconds and there is no change in the consciousness. So how do you want to manage the partial seizures and the generalized tonic-clonic seizures? The preferred drug of the partial seizures any day is carbamazepine. But carbamazepine in the young girls is not preferred. It is the one which is preferred instead of phenytoin because of the cosmetic effects. If you happen to use the phenytoin, a lot of gingival hyperplasia and the skin, they're all the challenges which are not there with the carbamazepine. Now, Valproate is a wonderful drug, the drug preferred in GDCS. But in children, if you want to give Valproate, you should remember hepatotoxicity. Now, what are alternatives? It is a lamotrigine, gabapentin, topiramate are considered to be good alternatives. Now, if you take the GDCS, the first choice any day is carbamazepine and phenytoin. Valproate, phenobarbital are second choice. Lamotrigine, gabapentin, topiramate, primidone, levetiracetam, all this you can be able to add on to these primary drugs like carbamazepine and phenytoin is what need to be remembered. Complex partial seizures there is a loss of consciousness, automatisms will be there and they last between 30 seconds to 2 minutes, consciousness is impaired and the patient looks confused or inappropriate with a dazed behavior that characterize the complex partial seizures. Generally, we use carbamazepine plus phenytoin or valproate. Refractory cases, we give levetiracetam, lamotrigine, gabapentin, topiramate, and zonisamide. Then what are absent seizures? The teacher says, the child is looking through me, he is not looking at me. That is the absent seizure, is what you need to remember. They last less than 30 minutes. There will be postural tonic changes, and there will be autonomic phenomena that happen in the absent seizures. You can give ethosuximide or valproate, but valproate is most commonly used because if you use valproate in absence, you can prevent the emergence of the JDCS, is what you need to remember. Lamotrigine is a good alternative. If you want a sustained response, clobazam can very much be given. So valproate is the first choice, ethosuximide and lamotrigine are the second choice in the case of the absent seizures. Then comes the atonic seizures. It is also called echinidtic epilepsy. The patient may suddenly fall down. Then myoclonic seizures. A typical child who has myoclonic seizures will be suddenly falling down. They are called salam spells, are the classical feature of the myoclonic seizures. Now, doc, if you look at the management of the myoclonic and atonic seizures, valproate is a preferred drug, lamotrigine is a preferred alternative, and you can add topiramate and levetiracetam. So, for the myoclonic and atonic, what is the drug that should stay in your mind in the tomorrow's exam? Valproate is considered the best, and levetiracetam and clonazepam you can add to the valproate in case of the myoclonic seizures, is what you need to remember. Finally comes the status epilepticus. When do you call it a status epilepticus? If it is lasting more than 30 minutes, is considered to be the important definition to call it as status, which is a medical emergency. Now, one of the favorite questions asked in the entrance is, what do you try first, then next, in case of the status epilepticus? So this you have to remember once more in the tomorrow's exam. January 6th, घंटी बज रहा है, नीट पीजी 2019 एग्जाम के लिए आप रेडी हो जाना. You will remember me in exam hall when they ask a question on status epilepticus clinical management. You give lorazepam 0.1 milligram per kg intravenously and at a speed of 2 milligram per minute. If lorazepam is not available, then you can give diazepam or phenytoin IV. And nowadays fosphenytoin is being preferred. Suppose if there is no response to phenytoin, then phenobarbital is used, which is 100 to 200 milligram. If the seizure is continuing, then you should be ready to give general anesthesia with propofol or thiopental as a last resort, is what you need to ultimately remember. So, doctor, all this list of drugs in status epilepticus management and their dosages also are the favorite question of the examiner, which you should not forget. Now, what are the newer anti-epileptics? Lamotrigine, gabapentin, topiramate, levetiracetam, zonisamide, tiagabin, vigabatrin, you should be doubly sure about. Oh, Nanda Kumar Neharkar, thank you very much for a small donation. Good, good. 2 days back, I just introduced a super chat feature just for fun, whether it is working or not. I really don't mean it. Thank you for all the guys who are very affectionately donating 100 or 200 bucks. Thank you so much. But you really need not do that. You all come to the class every day. You bring your friends to the class every day. I am the happiest And I always tell my colleagues, recently in the Association of Physicians of India when we met, one of the senior physician, his son is also attending in your group. He said that Dr. Sahab, we are all treating malaria and typhoid sitting in the OPD. At that time, you are taking the responsibility to create the more knowledgeable new doctors. So, the greatest gift you all have given to me is to be with me, to give me an opportunity to study along with you and spend a wonderful evening with you. Yes. Now, doctor, how do you, what are the 5 points you should know about lamotrigine? The lamotrigine's mechanism is similar to that of the carbamazepine, but it should not be used in children. It's a broad spectrum anti-epileptic. It has a half-life of 24 hours, which is a very, very important feature, and it is better tolerated than carbamazepine or phenytoin. And good thing is there is no negative effect on the cognitive function, especially children. If you want to use any anti-epileptic, they become very drowsy, become very difficult to manage in the school. So we always look forward for that anti-epileptic which does not affect the cognitive ability of the child, and lamotrigine has that special privilege, is what you need to basically remember. Then coming to the gabapentin. Gabapentin, it is a add-on to the first line of drug, and it reduces the seizure frequency in refractory partial seizures, and it can even be given as a monotherapy. Topiramate is fundamentally a carbonic anhydrase inhibitor. That is very, very important. Ravi asked a very good question. Carbapene's half-life. Somebody should check Wikipedia and quickly update him. Yeah, but was it an old question? Please remember, only if it is an old question, remember, otherwise don't. That is the most important thing. You should be quite limited to what are the things must to remember. You should be very sure. So I hope most of you have downloaded the UMedico app using the new notes feature. Yesterday there were a little technology bugs where all slides, all topics, same PPT was coming because of problem in the database. But they have corrected that, they have fixed that bug, and now you can check. You are having all the nearly around 70,000 PowerPoint slides which we used in all our lectures are all available. You can go bookmark it and then get the reminders, notifications, everything. I hope you will all enjoy that. Please give me a feedback how the notes feature is helping you, right, in the UMedico app. Now, doctor, topiramate is also a weak carbonic anhydrase inhibitor. Jonissamide also, especially in refractory partial seizures, it is the one which is, yeah. Snowbervani is asking where to download go to the Google Play Store, type UMedico, and you get the app, just download it and you can start using the feature. Somebody help Dr. Snowbervani to download the UMedico app, new version. Then levetiracetam, it is free of many drug interactions. That is one of the major advantage which you should basically remember. It is used increasingly common in complex partial seizures, myoclonic epilepsy, etc. And it suppresses the kindled seizures, which is one of the special effect. Yeah. So Devanshi Thakkar is saying, if lamotrigine does not affect the cognitive function, why it is not preferred in children? Once more, you need to look at that entire toxicity profile. Like ethosuximide is very effective, but ethosuximide you cannot give because of its effect on the vision, and the children cannot report it. So similarly, the overall toxicity profile doesn't make it a levetiracetam. So, I mean the lamotrigine, not a preferred one, right? Now, thiagabin, vigabatrin, how do they work? Thiagabin potentiates the GABA. It is added as a add-on to the partial seizures. Vigabatrin, it inhibits the GABA transaminase and it is effective in refractory epilepsy, is what you need to remember. So, in summary, if you look at the topiramate, it is safe in pregnancy. Very high response rate, main advantage. Main disadvantage, it has got a CNS adverse effects. And in renal disease, you need to decrease the dosage of topiramate. And it is one of the broad spectrum efficacy kind of a anti-epileptic is what you have to ultimately remember. Now, what are the neurological manifestations of the Whipple's disease is a very important question. So, you have seizures as a presenting feature of the Whipple. So, the Whipple is involving the gut. There are also neurological effects of the Whipples. So, dementia, ophthalmoplegia, myoclonus, altered level consciousness, hypothalamic dysfunction, then psychiatric anomalies, abnormalities and seizures, ataxia. They are all considered to be the important effects of the Whipples on the CNS is what you need to remember. If you have status epilepticus, what is considered to be the drug of choice is the favorite question of the examiner. Any given day, it is a lorazepam and you should know what is the dosage of the lorazepam. Now, what is the best drug for the photosensitive epilepsy was the question in NEETPG 2014 and 2015. So, you should remember it is a valproate. If you look at the sodium valproate, what's the mechanism? It blocks the activated sodium channels, not the one which are in a resting state. Please don't forget. It enhances the GABA synthesis. It reduces the degradation of the GABA. It suppresses the glutamate action. It blocks the T-type of the calcium channels, which is considered to be the important part of the mechanism. And other than epilepsy, where do you use it? Is another favorite question about sodium valproate. Bipolar disorders, prophylaxis of migraine, Lennox-Gastaut syndrome, they are the places where sodium valproate is used. Then in the epilepsy, almost all forms of epilepsy you can use valproate. GDCS, absent seizures, complex partial, myoclonic, atonic, photosensitive epilepsy. अगर epilepsy के बारे में एक क्वेश्चन आया और ऑप्शंस में valproate रहे तो if you err on the side of valproate, it is not going to ditch you. Be very sure about valproate. Now, where do you see seizures? In all conditions you see seizures. Where? CMV, cryptococcal meningitis, toxoplasmosis. They are all the various parasitic infections, fungal infections, viral infections, which can lead to the development of the seizures. Lafora disease. What is incorrect about Lafora's disease? You have myoclonus, autosomal recessive inheritance. DNA sequencing will help you to diagnose the Lafora. उसके पहले, what is Lafora? वो देख लेंगे. Lafora disease में you have seizures है, myoclonus है और dementia भी रहेगा. All the three. It's called a juvenile myoclonus because the onset is in the adolescence between 10 to 18 years. It is rapidly progressive. Death occurs before 25 years. And headache, difficulty to work in the school work, doing school work, and generalized seizures, visual hallucinations. They are all the problems in case of the Lafora. So, myoclonus, seizures, hallucinations, which gradually worsen and become intractable. Remember, doctor, metabolic disorders, neurological disorders, psychiatric disorders, unfortunately, they are all a spectrum. Without knowing the metabolic or a neurological basis, if the psychiatrist treats a psychiatric disease continuously, they will be missing a point. So there is a reason you should have that. You prepare for so many things and become a MD, right? You should always remember that since you read all these high-yield topics, tomorrow when you become a MD dermatology or a MD pathology or MD neurology, all this basic awareness helps a lot in that specialty which you are going to become great. Okay? Everyone of us ultimately are born to become great. Please remember that. We are born to become great. Already it was decided 6 years back when we got in medical school and we became a doctor, medical students. That day only you are the greatest. You are out of millions. You are the one who is being selected by the natural selection of Darwin. That's the reason you became a medical student and a doctor. It's only a little more everyday greatness that only comes when you are clinically practicing. And that is what you are striving for. So there's a reason, doctor. Make your heart strong. Say that I am the one who is being chosen by the Almighty to become the great. And hence I became a medical student. And this is only one more test that I am passing called NEETPG. The moment you think that way and make the best use of the next 25 days, I am very sure January 6th ke baad, we are going to break a champagne and celebrate a victorious outcome. That should be the goal. So now, doctor, what is Lafra's disease? Glycogen, due to the mutation, will form a Lafra body. And this Lafra body, unable to metabolize, will lead to collection in the brain and lead to the development of epilepsy, dementia, etc., is what you have to basically remember. Now, doctor, this glycogen, it become a Lafrin hyperphosphorylated glycogen that form the Lafra body, which will initiate the neuronal apoptosis epilepsy that constitute the Lafra's disease is what need to be remembered. So, what type of mutation is it? It's an autosomal recessive mutation, and age of onset is 8 to 18, and there is a cognitive regression, headaches, myoclonic jerks, visual hallucinations, and ataxia, dysarthria, mood disorders, etc., which are responsible, which are typically seen in the Lafra's disease. If you happen to do the biopsy, you can be able to see in the liver the presence of these hyperphosphorylated glycogen deposits, which are called as the Lafra's bodies, is what you need to remember. So, doctor, today preparation is very easy. You have all these images, all these videos, everything in the Google. So that's the reason whenever you are getting bored, watch one myoclonic seizure. If you want to look at how is in the real time, real scenario, status epilepticus patient, clonazepam de diye to he calmed down. If you want to see, even that video is there in the YouTube. So there is a reason YouTube, Google has made the knowledge easy at your fingertips. But what is needed? Motivation to utilize them. And then until the end of the game, reading every day, preparing every day, and filling all the gaps. That is the need of the hour. So how does Lafra present? As we already discussed, it is in the form of a myoclonic epilepsy. Excellent. Surya Prabha, Shviti, Sudha Shukla, everyone is right. It is a myoclonic epilepsy it presents. And where do you find Lafra bodies? You can see examiner के क्वेश्चन बैंक में सर्वर में लेफरा बैठ के आपको देख रही है. मेरे यार तुझे मालूम है या नहीं लेफरा क्या होता है? So that is the reason you should prepare with an intention what examiner is going to ask, right? So every year consistently lephra was asked. So it is a juvenile progressive myoclonic epilepsy is what you need to remember. Verocase Antony A bodies. Where do you find them? Verocase Antony A bodies. Schwannomas. So there are two types of growth pattern in schwannoma. One is called Antony A, where elongated cytoplasmic processes arranged like a fascicle with a very little stromal matrix. And Antony B is a loose meshwork of cells with myxoid and microcystic changes. That is Antony B. Verrucoid bodies, they are typically found in Antony A. So this is how a Antony A pattern typically looks like, where you can see the elongated cells present like arranged in rows of fascicles. That is what you are able to see. Now, where do you see retrograde amnesia? Right, Ravi is asking which type of seizures in lephera? Myoclonic. Now, retrograde amnesia is seen in temporal lobe epilepsy. So, we have discussed it already that if you look at the temporal lobe epilepsy, how does it present? There will be aura. 90% of times, aura will be there. Some epigastric sensation with a rising character, very non-specifically patients present. Sometimes like a fear, like a déjà vu, like a non-specific sensation, a tire burning, autonomic changes, that's how it presents. So olfactory, gustatory aura, they're all the presenting features is what you need to remember. Then visual and auditory will not be found in the temporal lobe epilepsy. What you find is olfactory and gustatory aura. And also there is a development of retrograde amnesia in case of temporal lobe epilepsy. So Samsung is asking, what is retrograde amnesia, sir? Remembering that we did not qualify in the NEETPG 2018, forgetting that fact, is called retrograde. Anterograde amnesia. December 25th, you studied a topic of hypertension and that question came on, let us say, January 2019, NEETPG. आपको hypertension क्या है भूल गए? That is anterograde. Recent memories is anterograde. What is the gender-specific side effect of valproate? You should remember PCOD, polycystic ovarian disease. तो valproate का पूरा साइड इफेक्ट्स टिप्स में रहना मेरे भाई. वेट गेन, डोज रिलेटेड ट्रेमर, ट्रांसिएंट हेयर लॉस if you still have some hair, polycystic ovarian disease, bone loss, ankle swelling, and the most serious side effect is hepatotoxicity is what you need to basically remember. And any increase of SGOT is a sign of the liver damage which you need to follow. Neonatal seizures. What is the drug of choice? This is a question asked at least 1000 times in the last 15 years. Various entrance exams. So be very sure. It is the phenobarbital in neonatal seizures. Atypical febrile seizures. What are they associated with? First of all, typical febrile seizures क्या होता है? और complex febrile seizures और atypical febrile seizures क्या होता है देखेंगे, right? If there is any focal or generalized and prolonged seizure, febrile seizure of a duration more than 15 minutes, recurring more than once in 24 hours, or it has a postictal neurological abnormalities like postictal palsy, then that is called a complex febrile seizure, not a simple one but a complex, otherwise a atypical febrile seizure. So simple febrile seizures and atypical febrile seizures के बीच में क्या फर्क होता है? Most commonly, it is a typical febrile seizure when a child is being brought by the mother where the child is having fever, very high grade fever, and he is having seizures. They are very apprehensive. क्या तेरे बेटा जिंदगी तमाम लेना है क्या डॉक्टर anti-epileptics को? What will you tell her? No, don't worry. Typical seizures, febrile seizures, high temperature की वजह से आता है. अच्छा टेम्परेचर कंट्रोल करो, कोल्ड टेपिड स्पॉन्जिंग करो, ब्रिंग डाउन द टेम्परेचर, आपका राजा बेटा बड़े बनके माल बनेगा. That's what you have to tell the mother. Reassure her. She will cry on your shoulder and go. And that is most important. And so these are all common FAQs, doctor, for every clinical condition. As doctors, it is just a small diagnosis. But for the patient, a new life starts. He starts living with that disease. So to live with something, you should learn how to live with it. You should know what it is. That's the reason we need to educate the patients about common FAQs that they have when a diagnosis is being final, like multiple sclerosis, rheumatoid arthritis, how the medicines work. That's all very important. So we have a YouTube channel similar to this called as CuroChat. CuroChat, C-U-R-O-C-H-A-T, CuroChat. So I will send you the link also of the CuroChat. So please subscribe to that link. Tell you also promote it and share it with your friends. From tomorrow onwards, I am starting the patient education series freely to the patients. And there are about 40,000 medical consultants globally who are ready to come for a live talk show with me, where I will be anchoring the session, asking them the patient's questions, and they will be answering. Some from the London, some in California, some in New York, some in New Delhi, Mumbai, top consultants in our network. So morning 10 to evening 8 p.m. there are about 10 shows that we run, and we want to help. Every month we run around 300 shows on the CuroChat YouTube channel. Common questions: how to use a nebulizer, and is it good or bad to take insulin? If insulin ले लिए तो उसका addiction हो जाता क्या? Lot of questions patients will have. As doctors, we don't get time. So that is the reason we started this YouTube channel called CuroChat. Please go to that, subscribe to it, and then promote it. And also give a talk show where I will anchor a show with you tomorrow when you join the MD, right? Now, with neurodevelopmental abnormalities, it is no more called simple febrile seizure. The age range at which the febrile seizures simple occur is between 6 months to 5 years. Please remember, febrile seizures do not occur below 6 months. That's very, very important to be remembered, right? Yes. Samsung is saying Curofy, not the app. Curo, not Curofy. It is CuroChat. C-U-R-O-C-H-A-T. CuroChat. Please, in the YouTube, you type CuroChat. It will give you the YouTube channel. You can subscribe to that and then participate in the live talk shows, right? Health talk shows. Then duration less than 15 minutes. Typically is the nature of simple febrile seizure. Now, what's the most common abnormality? Yes. Most common electrolyte abnormality causing seizures in hospitalized patients. Don is asking, is it for patient or for us? Doctor and patient more or less are same in the modern days of information era, right? So that is the reason sometimes patients are more knowledgeable. They will tell you, maybe I don't have indication for a total knee replacement. I will do it after there's a narrowing of the intra-articular space, after doing a CT or MRI. If they say no, you'll be stunned. Oh my God, this much knowledge they have about indications, contraindications, and complications. All because of the information era, right? That's good. Now, you should remember that in the hospitalized patients, very commonly hyponatremia is the most common dysarthritis leading to the development of the seizures is what you need to remember. So what is pycnolepsy? Is a Kanna JDP is saying there are only 35 subscribers, sir. Yeah, now we are starting. Just today only we started. So please, all of you, click on subscribe, and that way I can have another 15-20,000 subscribers in no time. Right? You will keep getting notifications on the live health talk shows. I got some of the top cardiologists, neurologists, nephrologists across the world who are ready to come and participate in the discussion of the case studies of the patient. Okay, now, so pycnolepsy means a status absent seizure is called as pycnolepsy. So, if you look at the absent seizures, they are less than 30 seconds in duration. 6 to 8 years is the common age. Inattentive student is the way they are recognized. Hyperventilation precipitates, and 3 Hz spike in slow wave pattern, classical of the absent seizures is what you need to remember. Sweetie is asking, what is meant by pycnolepsy, sir? It is a status epilepticus of absent seizures is called as pycnolepsy. If the absent seizures are happening recurrently within a single day, 100 times, 60 times, 50 times, that's called pycnolepsy. Now, a septic meningitis, can any drug lead to? Drugs, can they lead to? A septic meningitis is a very important question. Ibuprofen is the most common NSAID that is most frequent cause of the septic meningitis is what you need to remember. In TBM, what are the important CSF findings is my question to all of you. Thank you Kanna Jaideep for subscribing to the Curo Chat app. Please share it with your friends, everybody, family, other family members, right? Yes. So you should remember that there is a lymphocytosis, low sugar, high protein. That is what you find. So typically if you look at the TBM, straw colored CSF, no organisms are seen. Protein is around 250 and glucose is typically low, hypoglycorrhea, just like bacterial meningitis. In the cytology, lymphocytes will be 70% and ADA will be around 3.4 and more is what you need to remember. So this is one table, doctor. You should not forget, you should not do a mistake in the tomorrow's exam. Bacterial versus viral versus fungal versus TBM. Opening pressure. Bacterial में zup निकल के आएगा आपका CSF very high. Even TBM also. WBC count is between 1000 to 10,000 in bacterial, whereas in case of viral it is less than 300. Neutrophilic predominance is a feature of the bacterial meningitis. Protein, typically it is 150 to 200 in TBM and 100 to 500, but normal in viral meningitis. Glucose, you find a hypoglycorrhea less than 40 in TBM, fungal and bacterial. But viral viruses don't eat the sugar in the CSF, so it is more than 40. Gram stain is typically 60 to 90% positive in bacterial meningitis, and culture typically TBM and bacterial meningitis may 70 to 85% it will be culture positive, whereas fungal it is 25 to 50% culture positive is what you need to remember. Now, carcinomatous meningitis. Why does it? What is the most common cause for it is my question to all of you. It is a carcinoma of breast. Breast cancer around 34%, lung cancer following that is 26%. So breast cancer is considered to be the most common cause for the carcinoma of breast is what you need to remember. So this is an example, a patient 57-year-old woman came to the emergency with an altered consciousness. There is an irregular enhancement of the dura mater. So the dura mater is enhanced. That means there is a carcinomatous meningitis and carcinomatous invasion of the meninges is what you need to remember. Mulleret's meningitis. What are all the 5 to 6 points that you know about Mulleret's meningitis? You should remember that it is caused by the herpes simplex type 2 in most of the cases. So it is a recurrent inflammation, and there will be recurrent episodes of headache, meningismus, fever, and there is a CSF pleocytosis, and there are large endothelial cells in the CSF, which is very important feature. And epidermoid cysts in the CNS, they also can give rise to Mulleret's meningitis, but very frequently it is due to the HSV type 2 is what you need to remember. So, recurrent episodes of meningitis, spontaneous remission of symptoms, and episodes of symptom-free periods, and fever, though not always present, and transient neurological symptoms but no permanent neurological sequelae, and it is the HSV2 which is implicated in Mulleret's meningitis is what you need to remember. A 32-year-old HIV positive female, lumbar puncture shows leukocytes more than 100. India ink stain positive. What is your answer? You will jump and answer Cryptococcus meningitis, India ink positivity. Tomorrow examiner is going to give a image based question. Lot of times he gave about the Cryptococcus. Now about the TBM, once more a favorite question, NEETPG 2015 and 16. So CSF has got lymphocytic predominance and the count is high. Remaining are all true. Culture of the CSF is a gold standard, and it is also seen in young children but also develops in adults, most often in young children. And there will be evidence of old pulmonary infections, miliary pattern, where the dissemination happened to the CNS. They are all the features of TBM. Which type of meningitis you use steroids is a examiner's favorite question. Haemophilus influenza meningitis में अगर steroids का इस्तेमाल नहीं करे तो there is a great chance that it can lead to neurological sequelae like deafness, etc. So, if you say H influenza meningitis, 5 points you should know. Number 1, what age group do you see? Less than 6 years age? What type of subtype of Haemophilus influenza? Capsular type B causes more than 90% of invasive. It's a dangerous H influenza, type B. And what are the predisposing factors for the development of H influenza? Bhatia. Steroids, are they used? They are also used in TBM, absolutely, don't forget. TBM में खाली TB medicine से कुछ भी नहीं होगा. Dexamethasone, methylprednisolone. अगर आप दिए तो ही, even your PV drugs will have a penetration into the brain, is what you need to appreciate. Now, Ravi is very anxious about aura and postictal state. What is the big deal, doctor? Aura जो होता है, a feeling that I know all these people, the surroundings and all that. That is aura. But if you look at a person after having the seizure, either they will have confusion or they will be running away without knowing anything what is it, or they will be lying down dull, unable to move their hand with weakness, which is called Todd's palsy. They are all called postictal phenomena, is what you need to understand, Ravi. Yeah. Now, No, no, rocket trader, please don't say that. Ravi is my most favorite student. Um, always, what we are not very sure, no, small thing रहता है, उसको clear करे तो ही हमको वो anxiety निकलना. Then only you will become a topper. You should have that anxiety. अरे, why I didn't know this? Why I didn't know this? Then only you will get that always tension, anxiety of the exam should become a driving force to prepare. Let me tell you. Yeah. So now, treatment. How do you treat? Steroids, dexamethasone, and antibiotics IV. They are the ones which are preferably administered. Of course, all of you are my favorite students, no doubt on that. But I want you to get clarity. Before you go to exam only, you should know, oh, 650 topics, I know what is going to come, what is not, I need to bother, what are my weak points, what are my good points. First you should know, that is important. Pneumococcal meningitis. We give for about 14 days is the duration. For the Streptococcus pneumoniae, 10 to 14 days. H. influenza, Listeria, 7 days. Listeria, 14 to 21 days. Even Epilepticus. Then Pseudomonas, 21 days. Epidermidis, 21 days. And what is the drug of choice? This is a favorite question of the examiner. Listeria infections, pneumococcal infections, these are all capsulated organisms which are typically seen in the terminal complement component pathway deficiency is what you need to remember. That's the reason C5, C6, C7, they are all called terminal complement components. A patient is having headache, nuchal rigidity, normal glucose with a clear CSF. There are 50 lymphocytes, lymphocytic pleocytosis. What is your diagnosis? Once more, NEETPG 2015 question. Classical of viral meningitis. Normal glucose means no hypoglycemia. That means you will jump and answer it as the viral meningitis. Most of them are benign, self-limited. We give acyclovir for HSP1 and 2. We give ganciclovir and postcarnate as a maintenance dose for the CMV meningitis. These are the things that you need to remember. Now, patient has got a headache, fever, neck rigidity. Sugar is 60, protein is 68, opening pressure 190, 32% lymphocytes. When all these clues are there, what do you think? Without hypoglycemia, normal sugar is a leading differentiator. Lymphocytosis with a low sugar is equal to TBM. Lymphocytosis with a normal sugar is equal to, in the CSF, is equal to the viral, and that is Coxsackie virus is what you are going to answer. So once more, doctor, in viral meningitis there is a lymphocytic predominance and is what you need to appreciate. Now, eosinophilic meningitis. What are all the conditions that lead to it? Except. So you should know any metastasis, leptomeningeal metastasis, helminthic infections, coccidomycosis, they're all considered to be the causes of eosinophilic meningitis. What you are able to see here, classically, a cryptococcal meningitis patient with left frontoparietal area getting involved with a enhancement of the meninges is what you are able to appreciate. Now, in pneumococcal meningitis, what is the drug that you give empirically is a very important question. So, don't forget, doctor, meningitis, empirical treatment. Infective endocarditis, empirical treatment. You should be 100% sure about these topics. So, if you look at the Streptococcus pneumoniae, Listeria, H. influenza. For these three, what is the initial therapy, doctor? Ceftriaxone and vancomycin. Vancomycin, why? Because for a better streptococcal coverage. Listeria monocytogenes agar hai to, you should add ampicillin. If there is a MRSA pseudomonas, typically post-surgical neurosurgical patients or a skull trauma patients, switch ceftriaxone to cefepime or meropenem. Then what are the adjunctive measures? You add dexamethasone, especially pneumococcal, H. influenza, TBM. In all those scenarios, it will reduce the death. Then you have to isolate where droplet isolation is done, where patient cannot sneeze on others, until meningococcus is ruled out. And that is the most important thing. Now, what is the treatment of choice for the Listeria meningitis is a important question by the examiner. I am very happy to see 205 online viewers on this wonderful winter evening of December, right? All our life is fulfilled with the sharing of the knowledge. Always remember, doctor, when we are born on this planet, there is a deal of delivery. To do that, God sends us. So that's the reason when you are spending your birthdays, marriage days, engagement days, but still you are in hospital doing the duty, think that this is for what I have been delivered by the God, invisible God. So when I teach also, I feel every day evening, it is the purpose for which we have been delivered, and we keep delivering that purpose until we are alive. So that should be the spirit with which you should. So while preparing for NEETPG, what will you think? It is the purpose to become a MD, to become DM cardiology, DM neurology, that I have been born. My hands are created to become a plastic surgeon, cardiothoracic surgeon. And I am just delivering what I am born for. With that spirit, you go to reading room, everything becomes easy. If you are born for that, you will win it. That's a simple thing, right? So, Listeria meningitis, treatment of choice is ampicillin, is what you need to remember. Now, doc, if you look at the Listeria meningitis, please don't forget this. Ampicillin for at least 3 weeks. Gentamicin is added, especially in critically ill patients. And you use in penicillin allergic people, trimethoprim sulfamethoxazole is the one which is given every 6 hours. The next topic that comes over is Prion disease. So, what do you know about prion? Prion is not a virus. Prion is not a bacteria, not a DNA, not a mycoplasma. It is an altered configuration and structure of the protein which makes it pathological. So, infectious protein is a one which you see with the prion. So, this is a prion protein alpha helical protease sensitive. Then this becomes the resistant prion, which is a beta pleated sheet and protease resistant, is what you need to remember. Spongiform encephalopathy. If you happen to look into the brain in histology, you find spongiform changes. So where do you see it? In case of Prion disease is what you need to basically remember. So if you look at the human prion disease, there is a death of neuron cells, death of glial cells, amyloid plaque formation, and spongiform changes in the brain tissue. In the tomorrow's exam, examiner is going to give you one spongiform histology and ask you, looking at it, what do you remember? You should think, oh, prion is something that I will remember. Now, with regard to the prions, what is accept about it is my question to all of you. They can be inherited, they can be transmitted with the especially human growth hormone preparations, and they can occur sporadically and they can be transmitted via corneal transplant also is what you need to remember with regard to the prion. Now, Creutzfeldt-Jacobs disease. What is an important change that you see in the brain? There is a spongiform change in brain because the prion disease. The word spongiform should go and sit in your brain. Once more, NEETPG 2015 May, spongiform degeneration, where do we see is the examiner's question. It is a Creutzfeldt-Jacobs disease is what you should remember. Now, cannibalism. If the NEETPG examiner gets a brain biopsy, what will he get, doctor? What are the changes you will see? Spongiform changes, because he's the biggest cannibal sitting there, allowed to eat all your doctor's brains. So, cannibalism. So, typically, cannibals have croup is the thing that you all know very well. Abhi, masala topic of NEETPG exam, headache. Without a question on headache, there is no paper. And headache is also important for you to learn, because जब आप practice शुरू करते ना, your first patient is Arundhati auntie, who is the housewife. वो बोलता है कि डॉक्टर साहब सर में दर्द रहता है, कुछ करो ना. So if you happen to give a medicine, her headache doesn't go, no, पूरा दुनिया को बोलेगा क्या है तो बकवास पागल डॉक्टर है, सर दर्द ट्रीट करना भी इसको नहीं आता है. So that's the reason, always remember, doctor, tomorrow in the OP there are certain subset of your patients. Spend an extra hour, extra mile to make them happy. If you don't do that, if you do that, they will become your ambassadors to promote you, brand ambassadors. If you make them to their expectations fail, they will see that you close the clinic and run away. That is for guarantee. So headache though, you should know everything. Pseudotumor cerebri typically is caused by what are the underlying causes? Vitamin A toxicity, obesity, sudden stopping of the steroids, they are all the predisposing factors for the pseudotumor cerebri, which is also called idiopathic intracranial hypertension. So, there is an elevated intracranial pressure more than 20, but when do you call it as a pseudotumor? There should no intracranial mass, no hydrocephalus, no infection. Without that, if there is any headache, that becomes pseudotumor. That's the reason most of times pseudotumor cerebri is a diagnosis of exclusion is what you need to remember. Now, with regard to the treatment of migraine, very important question, doctor. So, what are the drugs that you want to use? Sumatriptan acts longer than Sumatriptan. Sumatriptan is used in the acute attack, but not for the chronic migraine. Sumatriptan acts on the serotonin receptors in the great vessels is what you need to remember. So, triptans are a very crucial part of the clinical management of the migraine. So, how does it basically act? Triptans. They are going to act on 5-HT1B/D receptor. They prevent the peptide release, and that lead to vasodilation, neurogenic inflammation, and pain. So that is very, very important. And they act on the cranial vasculature via HT1BD receptor, and they lead to vasoconstriction, which is the underlying mechanism for the triptan is what you need to remember. Now, migraine बोलने के लिए what are the diagnostic criteria? Number 1, more than 5 attacks lasting 4 to 72 hours, and it should be unilateral, not bilateral. Probing, moderate to severe intensity, And if you do routine physical activity, there is an aggravation, which is important part of the definition. And there should be more than one of the following: nausea or vomiting, photophobia or phonophobia. These are the important components to call migraine, and no other reason to attribute that headache is what you need to remember. Two types of migraine. I hope those who have downloaded the UMedico app, already we discussed in the high yield topic theory, 650 topics ka. And also you have videos in the DNB last 15 years question bank, topic wise, subject wise. डिस्कस करके नोट्स भी दे दिया. अगर ये टॉपिक हेडेक का टॉपिक जरा लिटिल लीकी लग रहे तो just go back to the UMedico app courses, then go to the DNB and then medicine, neurology. In that you have the notes and also the video. Yeah, so that is very, very important. So migraine without aura is called common migraine, with aura is called classic migraine. So focal neurological symptoms, if they precede or sometimes accompany the headache, then you basically the thing which is called migraine with aura, which is called classic migraine. So how do you treat migraine is a very, very important question. Acetaminophen, aspirin, coffee. Wow, Rocket Trader gives a very good logo, Chai Pe Charcha, that's good. So acetaminophen, aspirin, caffeine, simple analysis. Chai Pe Charcha is required. NSAIDs, naproxen, ibuprofen, they are the ones which are also, yes. Next, 5-HT1 agonists we use, serotonin agonists. Orally you give ergotamine, naratriptan, rizatriptan, sumatriptan, almotriptan, zolmitriptan, oral. Nasally you can give sumatriptan, zolmitriptan and dihydroergotamine. Parenterally, dihydroergotamine and even sumatriptan can be given parenterally. They are all the 5-HT1 agonists. Is a very, very important question. Then what are the dopamine antagonists that you give for the treatment of serotonin agonists, dopamine antagonists? Orally you can give prochlorperazine and metoclopramide. Parenterally, chlorpromazine, metoclopramide and prochlorperazine. Then sometimes we use combination. Acetaminophen, dichlorpherazone and isomethapine, methamphetamine. Then nasally you can give butorphanol, parenterally narcotics. Now suppose if you are using NSAIDs, analgesics, patient is not improving, then what are the first tier drugs? Then slower effect but better tolerability drugs, and if it is not that frequent as the classical migraine, in that situation what do you want to do? So sumatriptan, almotriptan, rizatriptan, all triptans are fundamentally thought to be the first tier anti-migraine drugs. If there is a failed NSAIDs is what you need to basically remember. Then if the patient is having vomiting as a major symptom of the migraine, then zolmitriptan nasal spray, sumatriptan subcutaneously can be given. Suppose if it is a menses related headache, then to prevent you can give ergotamine perorally, and treatment you can give triptans and dihydroergotamine. And suppose if the symptoms are developing very rapidly, then you can give zolmitriptan, sumatriptan, dihydroergotamine is what you need to ultimately remember. Then next important question, एक्यूट एपिसोड के लिए ट्रिप्टान से सब इस्तेमाल करते हैं. प्रिवेंशन के लिए, chronic prophylaxis के लिए, what are the anti-migraine drugs that we use is a favorite question of the examiner. Beta blockers like propranolol, preventive. Tricyclics like amitriptyline, nortriptyline, docilipine. Then anticonvulsants like topiramate, valproate, gabapentin. And serotonergic drugs like methotrexate and flunarizine is what you need to ultimately remember. Now what are the various metabolic causes? So doctor, please remember one of the important point that you should, migraine treatment. Tonight only you should make it a emergency session and then review it in the U-Medico app. You need to bookmark it, set up reminders and be ready, equipped for the tomorrow's exam. Okay. Now, these are all the metabolic causes of the headache. Hyponatremia, hypercapnia, hypoxia. It is the hypoglycemia which is the underlying cause. What are the contraindications for the triptans? Amarendra says, sir, add a speed up feature in U-Medico app videos. I'll try. I'll talk to my developers to add that feature since I got the same request for my good number of students. So, you should give me a feedback. Are you enjoying that notifications, reminders and the notes feature in the U-Medico or not? You click on the video, you have that relevant video of that topic. So that is there. And many more question banks, AIMS, JIPMA, then PGI, all the question bank discussions that we had, both notes and videos are getting uploaded. You are going to enjoy the U-Medico app fully. Yeah. Now, Sumatriptan. We should remember that ischemic heart disease, pregnancy and bacillar migraine. So, contraindications for Sumatriptan is a very important question. Yes. Coronary artery disease and ischemic cardiac disease, they are the contraindications. Then triptans can lead to coronary artery vasospasm, arrhythmias, and they have a lot of interaction with SSRIs and MAVO inhibitors. Now, what is the cause of the primary headache out of all this is a very important question. Migraine, cluster headache, tension headache, they are all called as the primary headaches is what you need to remember. So, that is a part of the story. Yes. Can you load the continuation? Yes. Alarm is not working in notes. Yeah, I understand, Chintal. But you can toggle the slides by flipping under your finger. Have you appreciated that feature is working? And now our guys are making it how to read that note slides if you happen to turn the phone also in a big way where you can be able to spread it and read it. Okay? Yeah. Let's complete few more questions before we go to the quiz. The next topic of choice in the NEETPG examiners agenda, raised ICT. Where do you see raised ICT? The predisposing factors are inspiration will raise ICT. Then coughing, Valsalva maneuver, anything can raise the ICT. When you have a raised ICT, headache, confusion, shallow breathing, increased BP and nausea, they are all the classical features. Now, what are the various causes of raised ICT? Any intracranial hemorrhage, vasculitis, neoplasm, hydrocephalus, pseudotumor cerebri, hyperadrenalism, attitude sickness, outdated tetracyclines if you take outdated tetracyclines, patients will develop pseudotumor cerebri And vitamin A intoxication also, one of the causes for the development of pseudotumor cerebri is what you need to remember. A patient after an accident was unconscious. Unilateral pupillary dilatation. What is the main reason for this is an important question. Typically, when there is unilateral pupillary dilatation, for example, if there is any fracture, there is a bleed, and that bleed will push the brain and make the transtentorial herniation of the uncus. When it herniates, it will push the brainstem to the opposite side, and from the midbrain, the opposite side's oculomotor will be coming out, and that becomes compressed is what you need to understand. So, that is how the uncal herniation. Ipsilateral third palsy, ipsilateral hemiplegia, where do you see? We see it in case of the uncal herniation. Classically, whenever the tentorium, whenever the temporal lobe of the temporal lobe uncus herniates, it will push the brainstem and lead to the compression of the oculomotor nerve coming out of the midbrain, and also in the midbrain the descending pyramidal tract also is involved, and so that's the reason there is a development of hemiplegia. Where is Weber syndrome? What is the features? Already we discussed. The deep penetrating branches of the posterior cerebral artery will lead to the development of Weber syndrome. So, what are the features of it? It is the dorsal midbrain which is involved, and through the dorsal midbrain, in the dorsal midbrain you have third cranial nucleus. So, there is development of ipsilateral third cranial nerve palsy, and the descending pyramidal tract descends to the midbrain, pons, medulla, goes to the opposite side. So, that is the reason contralateral hemiplegia, ipsilateral third cranial nucleus because of the dorsal midbrain injury, because of the posterior cerebral arteries penetrating branches into the midbrain, they got occluded, leads to the development of the Weber's is what you need to remember. Pica occlusion, favorite question of the examiner. You will all remember, it is the lateral medullary syndrome of the Wellenberg. Transtentorial herniation. You can see how important are these for the NEETPG examiner. What are the important features? There is a ipsilateral hemiplegia, Cheyne-Stokes respiration, ipsilateral dilated pupils. They are the classical features which you see in case of transtentorial or the uncal herniation is what you need to understand. So, if you look at the various types of herniations, CNS herniations, there is one subfalcine herniation. This is the false cerebri, no doctor, separating the hemispheres. When there is a subfalcine herniation, then it leads to headache, and this is the area typical of anterocerebral artery territory, cerebral pulse area. This is the anterocerebral artery territory. Anterocerebral artery occlusion में क्या होता है? Contralateral lower limb monoparesis होता है. हम बहुत बार डिस्कस कर चुके हैं इसको. So, you have a contralateral lower limb weakness, leg weakness, if there is a subfalcine herniation. Transtentorial में oculomotor palsy, which is ipsilateral dilated pupil will be there, and contralateral hemiparesis will be there, is what you need to remember. And tonsillar, cerebellar tonsillar herniation अगर हो गया तो obtundation, patient will be in a semi-comatose state, is the classical feature. Now, A waves in intracranial pressure monitoring, what do they indicate? पहला intracranial pressure monitoring में waves होता बोल के आपको मालूम होगा, उसमें then A wave क्या होता है देखेंगे. It is seen in brain herniation. So, normal इंट्राक्रेनियल प्रेशर को अगर मॉनिटर करें तो क्या क्या वेव्स रहेगा? There is one P1 representing arterial pulsations, P2 which is called the tidal wave, which represents the compliance of the intracranial space. P3 is dichrotic wave representing the closure of the aortic valve. These are the three important waves that you find in the normal intracranial pressure waveform is what you need to remember. Then you have Lundberg A waves. What are the Lundberg A waves? Otherwise called plateau waves is the name given. Whenever there is a reduced intracranial compliance, then the amplitude of the waves become very high, 50 to 100 millimeters of mercury, and a longer duration, 5 to 10 minutes. And they are called the Lundberg's A waves is what you have to basically remember. So this is how a Lundberg's A wave typically look like, which is having a high amplitude is what you need to remember. So if this is a normal ICP waveform, P1, P2, P3 waves. Sometimes P1 is elevated, amplitude is increased in hypertensives. Hypertensives also will have raised ICT, right? But an abnormal ICP with an increased pulsation or brain compliance will lead to Lundberg's A waves. Then if the amplitude of the P2 is increased means there is some mass or a congested brain inside the calvarium. That is the meaning of a aggravated P2 wave is what you have to remember. So P1 is percussion wave, P2 is tidal wave, P3 is dichrotic wave, and how a compliant versus non-compliant. Non-compliant brain may P2 become elevated. That's what you have to basically remember. Now, what is wrong about Mannitol is a very, very important question. So, doctor, 226 online students हम बहुत खुश हो गए. So, Mannitol. If you look at the Mannitol, it increases the cerebral oxygen delivery. If there is a prolonged usage, it can lead to blood-brain barrier damage. Used in cerebral edema, all of you know very well. So, they are all the true statements. If there is an intern who has never used or written a prescription of Mannitol, then you have not done the internship only. So, after road traffic accident, blood pressure is 90 by 60, but the heart rate is around 56 ppm. So, what is the inference of you is the examiner's question. So, it is typically a neurogenic. Now, you have hypovolemic, distributive, cardiogenic, obstructive, that's how you divide. So, if you look at the JVP, hypovolemic and a neurogenic or a distributive shock, it will be low, but it will be high in cardiogenic or obstructive shock. If you look at the heart rate is normal or decreased in neurogenic shock. That is what you need to remember. So, that is the reason in view of the 56 beats per minute, we consider the type of shock as a neurogenic shock is what you need to remember. Now, how do you manage? A raised intracranial tension is a very important question. We elevate the head end of the bed, Mannitol, anesthesia, they're all the options. So, how much head end is elevated? Very important question. 30 degrees is what you need to know. And you need to give sedations, muscle relaxant, maintain a normocapnia. You will be hyperventilating the patient so that you will enable carbon dioxide to leave the body, and very commonly ambuing is being done to bring the normocapnic state in high ICT patients. Diuretics, furosemide and Mannitol. You need to give good seizure control, normothermia, sodium balance, barbiturates. They are all considered to be the important part of the management. Lastly, let us hit the topic of neuralgia before we go to the quiz. Now, that's what Ravi is asking. Hyperventilation. Very much. We do hyperventilation and purge out the carbon dioxide and maintain a normal or a low CO2 levels in cases of the raised ICT patients is what you need to remember. Crimmins test is done for what? You have to remember, for the facial nerve. So, normally tears of a person are going to be up to more than 1 centimeter per 5 minutes. Speed, they should form and cause a coloration. So, you want to know the aqueous level of the tear. You look at how much part of the strip is wetting. That's what you will be able to identify by the Crimmins test. Then, which aneurysm lead to third nerve palsy? Pecom aneurysm, very close to the midbrain. So that is the reason the junction of PCA with ICA is called Pecom, and the Pecom aneurysm, posterior communicating artery aneurysm, lead to the development of third nerve palsy. Thick dolorex, fifth cranial nerve, all of you know very well. But now I want to ask you a question. If the thick dolorex like pain happens in a young female, 21, 22, what is the diagnosis that comes to your mind? Whoever answers this correctly is going to get the NEETPG 2019. If you find in a young female, 22, 23, intense pain like thick dolorex, what is the diagnosis that you have? Syed Ilyas tried a good try, but it is not true. It is not hysteria. I'll give one more clue. Excellent! Sweetie Verma Jindabad. Sweetie Verma is going to join MD. Take it as my word. Right? Multiple sclerosis. Even Mitesh Kulkarni and R. Sharma, Amit Jaiswal, Shika Munka, Thug of Hindustan. हम बहुत खुश हो गए. Now, cranial nerve commonly compressed in an intracranial aneurysm. Which one? It is the oculomotor most commonly, the one which is compressed. Pecom aneurysm. Once more, you see how frequent is that question in the examiner's question bank. It is the oculomotor. Then Millard-Gubler syndrome कहाँ होता है brainstem में, किस जगह पे होता है, उसके वजह से what are the presenting features is the favorite question of the examiner. So, it is the 6th and 7th. Ventrocaudal pons. Pons का एक cranial caudal रहता, ventral dorsal रहता. So, ventral part, caudal part of the pons is involved, where the 6th and 7th cranial nerve nuclei are leaving, and that lead to obviously contralateral hemiplegia, because still the pyramidal tract while passing through pons is uncrossed. It will go down to medulla and then it crosses to the opposite side. Then ipsilateral lateral rectus paralysis because of the cranial nerve 6, and ipsilateral facial paralysis because of the cranial nerve 7 is what you need to remember, which is called Millard-Gubler syndrome is what you need to remember. You need to go back to the U Medico app, where in the notes in the DNB and the high yield topic wise brainstem syndromes in the neurology. You have to go there, review that video, bookmark the important slides in the notes. Very high yield topic for the MD entrance. Very good. Povilis syndrome, Millard-Gubler, then Benedict syndrome, all this you should be good. Now, 7th and 9th nerve, इसका integrity का test क्या क्या होता है? Taste, it definitely tests. Chordae tympani is a branch of 7th and posterior 1/3 is by the glossopharyngeal. The symmetry of the palate to know the 9th nerve. Position of uvula to know the 9th nerve, glossopharyngeal. But tongue protrusion is a test of what? It is a test of hypoglossal is what need to be remembered. So, if you are having a right hypoglossal weakness, when you ask the person to protrude, will the tongue move towards the right side or to the left side? The tongue will show deviation towards the right side, which is the side of the weakness. Why? Always the hypoglossal nerve supplies the tongue muscles which push the tongue to opposite side. If they are weak, opposition will push them ipsilaterally. If the right sided is, right side's काम क्या है? tongue को left को push करना. अगर वो काम नहीं करे तो the left will push the tongue totally unopposite towards the right side. So always the deviation of the tongue will be ipsilateral to the side where the hypoglossal is paralyzed is what we need to basically remember. The right 12th nerve damage will lead to, देखो कितना चिकनी क्वेश्चन पूछा एग्जामिनर ने. He will exactly catch you at your jugular. You should be ready to attack the examiner. अच्छा, cranials पूछ रहे क्या? Hypoglossal पूछ रहे क्या? मुझे मालूम है तू क्या पूछ रहे हो जनाब? And you should answer. That should be the spirit of attack. Tongue deviation will be towards ipsilateral to the side of the hypoglossal is what need to be remembered. So the hypoglossal arises in the medulla. It supplies all the muscles of the tongue except palatoglossus is what you need to remember. And it leads to the deviation of the tongue towards the ipsilateral side because of the unopposed action of the genioglossus of the normal side. And it leads to any nuclear level involvement of the hypoglossal in the medulla is an element type. So it leads to flaccid paralysis of the tongue. But bilateral corticobulbar get interrupted, what is that called? Pseudobulbar palsy. Then also hypoglossal is involved but UMN type. So there the tongue is not flaccid. So they will also have dysphagia, dysarthria, dyspnea, difficulty in chewing food. They're all the problems in hypoglossal nerve. Paralysis is what you have to remember. Now, cranial nerve 8 paralysis. It lead to vestibulocochlear है ना, इसलिए tinnitus, vertigo, motion sickness, etc. etc. Gag reflex का, gag reflex means you'll be checking how the palate moves if you touch it ventrically. So glossopharyngeal carries the sensory and the vagus is the motor. And what is that motor activity you are looking for? You are looking to move the palate. And if there is any vagus involvement, then the uvula will deviate towards the opposite side. That is what you will appreciate in case of the gag reflex is what you need to remember. Gag का G होता है cranial 9 which is sensory. Then AG vagus में आता है और वो होता है motor. The efferent is what you need to remember. Dorimos canal, what does it carry? Actually it is Dorello canal is found on the medial part of the petrous ridge and it channels the abducens is what you need to remember. Strabismus, diplopia, ptosis, they're all because of the damage of what? You know very well, the extraocular muscle. Oculomotor palsy classically leads to diplopia, ptosis, strabismus is what you need to ultimately remember. So that brings us to the end of our knowledge invasion. Now the time unfreeze your fingers. Let's go for the quiz. Yeah. So I hope you all guys are in a great spirit of preparation. Bubbling. Can you give me down? Bubbling every day, every moment, every second, living in a wonderful spirit to win the exam? Yes. Now doc, let's run for the answers. Ritvik says DNB 2018 June discussion please. If I remember, I already did that. If I did not, I will do that. No problem. Yay. So all of you are saying A versus C. Chronic vomiting. It is hypokalemic, hypochloremic because HCl is getting vomited. And metabolic alkalosis is correct answer. This is one thing that I don't want you to do wrong. Where do you see normal anion gap, doctor? Quickly. Is the DNB exam over or is it still there? Is the DNB still there? Yeah. If so, then when is DNB खत्म हो गया ना? Already? It's still there, DNB. Okay. I can see Sudeepti, everyone is saying renal tubular acidosis, absolutely. Increasing anion gap is the important question. So, Sneha is asking ophthalmology. You can just go to the UMedico app, you have a video library in that. Both NEETPG, DNB, AIMS, PGI, all these question banks have been discussed year-wise, topic-wise, so you can review that. Yes. So, no more DNB in December. Oh, very good, good. So, it is starvation, diabetic ketoacidosis, they are all increased anion gap. Pulse rate 108 and SBP is 80. What is the best solution you want to give? 154? Should your answer? Very good. Monica proposes normal saline. Absolutely right. These are all the features of hypokalemia except one. So ECG is a favorite area, doctor. You should be doubly sure. 155. Good. Ravi proposes B. Excellent. Tall T-wave is a feature of hyperkalemia, as all of you know. Hypokalemia, metabolic acidosis. Where do you see this combination? 156. Fat answer karo. Yes. 156. Shoot your answer, doctor. Very good. Monica is saying Conn syndrome. But who said Abhijit? Excellent. Diarrhea. Diarrhea is making you to lose the bicarbonate rich colonic secretions and also it lead to hypokalemia. That's right. Cons is hyperaldosteronism, doctor. So उसमें metabolic alkalosis होता है, acidosis क्यों होता? That is how those who answered D, like Vishalakshi or Greenbold. Already we discussed this. We should not do this wrong. Sandeep also did wrong. Acidosis रख के cons कैसे answer करते मेरे भाई? You are Dr. Murali Bharadwaj students. Should not do this wrong. Cons होता है hyperaldosteronism. Already we discussed now. Metabolic alkalosis is saline responsive or saline unresponsive. Whatever it is, the underlying common denominator क्या होता है? All metabolic alkalosis में hyperaldosteronism. Aldosteronism will be, what will aldosterone does? Sodium retention in the renal tubule. Can you give me the board, please? Can you give me the board? जो टॉपिक हम खत्म करते ना, अगर उस टॉपिक के अंदर आप if you are still answering it wrong, then मुझे हार्ट अटैक आ जाता, right? So yes, should not do this wrong. You have glomerulus, then you have Bowman's capsule, proximal convoluted tubule, then this becomes the collecting duct, distal convoluted tubule here and collecting duct. What is the action of aldosterone? It retains the sodium, preventing it from entering into urine and secretes K plus, H plus into the urine. So that is the reason H plus is lost into urine Hence, metabolic alkalosis will be there. Second, K plus is lost into urine. Hypokalemia will be there in these people. Not metabolic acidosis. Please be very sure. Right? So, how do you treat aldosterone metabolic alkalosis like this? First of all, why aldosterone is high? If the person is dehydrated, there is a decreased perfusion to the renal tubule, and the decreased perfusion will decrease GFR, and decreased GFR is sensed by the macula densa. It will increase renin production, and that lead to angiotensin, aldosterone production, and that high aldosterone will lead to sodium retention, potassium and H plus loss into urine. So इसका ट्रीटमेंट क्या होता? डिहाइड्रेशन को क्यूर करो, सलाइन दे दो. इसलिए metabolic alkalosis with underlying denominator is high aldosterone, and if that is due to dehydration, it will be saline responsive. Second reason why metabolic alkalosis occur is if there is any adrenal adenoma like cons, that also lead to high aldosterone, and high aldosterone will lead to all this metabolic alkalosis by losing H plus into urine. So there to treat the metabolic alkalosis, you give a aldosterone antagonist like spironolactone, triamterene, etc. Again, acidosis, alkalosis, dyslipidemia, 30 out of 30 mark आना general medicine में, then only Dr. Murali Bharadwaj will be happy, right? Yes, I can teach this 100 times also to you. Okay, now thank you Sam Singh for calling this awesome, definitely, but already we had this awesome discussion. So still if we do this wrong, we should be careful. Okay, now seborrheic dermatitis, cellulitis, alopecia, apathy. 157. Definitely. Thank you, Abhishek. Question number 157. Yes. World Cup देखा ना आप? World Cup जब हम जीत गए, they lifted the Sachin Tendulkar and champagne open किया, right? That should be the spirit when we win the 2019 NEETPG. So that is what we should dream, right? Now, it is the biotin deficiency which lead to the combination of all this. Once more, this is a repeat question. Here, where do you see question? Once more, this is a repeat question of renal tubular acidosis. Okay, widened anion gap is seen in all these except where it is not a high anion gap but a normal anion gap. Question number 160, 160. Shoot your answer, doctor. Very good to see 215 online students. Please don't forget to subscribe for this channel, that is youtube.com/onlinembbs. Share this channel with all your friends on Facebook, WhatsApp, everywhere, so that the number of subscribers will increase. Also go to the Curo chat. I am typing for you here. Somebody type the URL of the Curo chat YouTube channel. One of you, please type that. Also go to that channel. Please subscribe to the Curo chat, CUROCHAT YouTube channel. We are going to have a lot of health talk shows, a lot of consultants worldwide doing case discussions for the lay population, to the lay public, and we are going to do a lot of times patients ask, doctor, this drug, how does it act? How does digoxin act? I'm going to teach pharmacology to the common people so that they understand what medicines they are taking, how are they working, right? Curo chat, that's good, that's good. So Revati, please go to the Curo chat on the YouTube channel and please punch the address over there for the benefit of everybody. Right. Uh, that's good. So you should remember diarrhea, absolutely, right? If the gut is the cause for the normal anion gap metabolic acidosis, what will happen to the urinary anion gap? Will it be low or will it be high? Is a very important question. Urinary anion gap will be negative if the gut is the cause of the normal anion gap acidosis. This also we discussed last time. So please um, uh, review the whole video in the UMedico video library. They will upload that. Please review that video. Now doctor, severe combined immune deficiency में क्या दिखता है आपको? B cell दिखता, T cell दिखता, both दिखता या NK cell? Yes. Should your answer doctor? What do you see in severe combined immunodeficiency? Amit Jaiswal want to bet on both, most of you? Absolutely. Hence called combined immunodeficiency. Burger's disease में what is not involved? Is it the nerve, lymphatics, small artery or a vein? It is not involved in Burger's disease. 162. Ravi, Syed Dilias, they are differing between A and D. Sweetie thinks small artery. Very good. Amit Jaiswal, Rocket Trader, Jindabad, lymphatics are not involved. Apache 2 score में ये सब कुछ है, मगर क्या नहीं है? In Apache 2 score is my question to all of you. Should you answer? Ravi thinks serum amylase. Sandeep thinks arterial pH. And Santosh thinks GCS. Serum amylase is not involved in Apache, doctor. Burger's way, what is the site of the pain? Where you find the thrombangio obliterans. Burger may, what is the site of the pain? Classically, 164. Good. So, Amit Jaiswal thinks hand pain. Jaideep thinks cough pain. Very good. Most of you are thinking cough pain. Classically, smoker, thromboangiitis obliterans, leg pain, claudication is a classical feature. Central line, किसमें डालते? Central line. You will put in all this a central line. Of course, we put less commonly where, but most commonly where. 165. Even external jugular also. It's not that we don't put in external jugular. This is actually a wrong frame of question. Rectal temperature in hypothermia should be less than how many degrees Celsius? You call it as hypothermia is an important question. Yes. 166. I can see Ravi on A, Ankita on B, and Mitul Kirani on C. 35 degrees, doctor. Numerical. Now, कैंसर के वजह से होने वाले मृत्यु में मोस्ट कॉमन कैंसर लीडिंग टू मृत्यु and giving you passport to and visa to go to Yamalok. What is that? So, Maunika is proposing lung cancer. Most of you, except Sam Singh, think skin. I know Sam Singh want to become a dermatologist, but C is not right. Leptospirosis में what is except about it? Ranjit is on 168. Yes. Ravi is on Cipro. Good. Sai Maunika also is on Cipro. Sudipti, our Telangana Scud missile, is on jaundice. Jaundice, Sudipti. Malaria, leptospirosis. Common Telangana, Mehboob Nagar district farmer comes with jaundice means two things. Lepto हो सकता है, viral hepatitis हो सकता है, malaria हो सकता है. Malaria and lepto very similarly looking. So you should not do this wrong. Very good. Penicillin, doctor, crystalline penicillin is the drug of choice for the lepto is what you need to remember. Very commonly seen in at least there are 200 cases of leptospirosis. Terminally ill, dialysis karke, uremia manage karke when I was in Nizam's Institute of Medical Sciences. So very common in Hyderabad and Telangana. Now doctor, defective DNA repair, where do you see? Is an important question. 169. Should you answer, doctor? Defective DNA repair. Where do you see? 169. Correct. Workers working in sewage, farmers. Lot of times I used to ask, rat urine kuch milan hone ka chances hai kya? Patients used to look at me like a crazy, useless, one of the three idiots they used to look at me, right? So I never know patient give me history of rat urine, so they talk a lot. Huh? So who will remember kaun sa rat kiska urine ke wajah se wo ho gaya? Very good. I can see A versus C. Who said B? That's right. So Xeroderma, Werner, Bloom, they're all defective DNA. What is wrong about Paget's disease, doctor? Paget. Yes. 170. I like to know if you put up a alarm and notification reminder in the UMedico app notes, are you getting the reminder notifications? I just want to ask from the students who are already using the UMedico notes feature, are you getting that reminders? Please report any bugs to the WhatsApp our helpline so that quickly we can tell our programmers to do that correction. Okay. So notes is a hallmark feature. I'm very sure you will all be very happy. Okay. Ayush Singh says it is not coming. Okay. Yes, sir. I just got one now. Okay. Okay. So the funda is if you have put, for example, 500 slides in different topics ko reminder lagaye to every 15 minutes it keep reminding you one point that you set up reminder. एक घंटे में 4 reminders आता, एक दिन में 96 reminders आता. As you keep setting new points for reminder, it will keep creating a stack and then keep sending you the reminders. So that is the reminder feature. Please check whether the reminder feature is working in your UMedico app or not. That is going to help a lot. Similarly, you also have a sort option. You can only revise those points most bookmarked by everybody. That way, or most reminders people have set up, or those points which are most viewed by the people. You can sort the slides and can be able to watch them. That is an important feature. Yes. UMedico is a good slave. Yeah, very good slave to you. She is a very good, beautiful personal secretary for you. That I can definitely vouch you, right? But the only thing is you have to check whether she is working or not, or she is having an ovulation and notifications are not coming. You have to tell me, right? Now, Paget's may classically, there is a high cardiac output, high output failure, that's right. Now, regarding mycosis fungoides, the cutaneous T-cell lymphoma, leukemia, what is your answer? That itself is answered. Yes. So, it is a malignancy. Yes. These are all the FMGE questions. Previous 15 years FMGE questions I am playing with you as a quiz. But some questions are really very tricky. You will think something and go wrong. Right? So, immunomodulator, which is the agent, 172. Ravi bets on irinotictan and what else? Samsung bets on mycophenolate. Sweetie thinks mycophenolate. Surya thinks irinotecan. It is lenalidomide is a immunomodulator, is what you need to remember, right? What are the marker tests for the vertical transmission of HIV? Very good question. Very important marker, which is also used in the window period. Yes, 173. Ravi Khandia's Shubham, everyone is betting on P24. Absolutely right. Now, what is the 30-year smoker who is being shown to you here? What is the condition that he is suffering from? 174. Should you answer, doctor? Yes. Ravi Kumar thinks Burger. Ankita Tripathi thinks atherosclerotic clot. Absolutely, it is a Burger's disease. 20-year-old, abdominal distension, no urine output. What is the likely cause? Question number 175. Yes. So, even this quiz also, I am asking our people to, daily quiz is being uploaded into the UMedico app. You can play the quiz before you come to the session, and we can have the results of daily quiz toppers, which will stimulate you, right? So that is the plan. So everyone is saying the most likely cause, some of you are betting on B, but the likely cause, abdominal distension, no urine output means it's a little tricky question. Spleen rupture is a possibility. Now, what do you see in this image classically? Do you call it a CT MRI? Come on, easy question. Digital X-ray, क्या बोलता चाहते हैं इसको? 176. Ravi Kumar thinks scintigraphy. Oh my God. Ritvik Kanmuri thinks MRI. At least I did not ask, is it T1 weighted or T2 weighted? Good. Always soft tissues can better be appreciated on MRI. Trendelenburg's test is done for what? Yes. So, yes. Yes, why not bladder rupture? Good question, Monica. I'm also thinking the same. Yes. 177, most of you are saying varicose, absolutely. Myelin figures in necrosis is due to what is the question. So very happy to see 230 online viewers. Please call more of your friends to join everyday evening session, and also you download the UMedico and you share this YouTube channel to all your friends. These are the three things I want. How many of you are the new students? Please punch. First time or second time attending this session, please punch. Who are the new students here? So I can see Amit Jaiswal, Krishna Saumya, Monica, Somesh is a new student, very good. Please call our helpline 9000868356. Even Naveen Kumar, Sandeep Purnia, Suresh Birja, and Manish Singh. Very happy to see all of you. Dr. Jai Kishan. Every day evening, all 365 days, free coaching for you. Mera जिम्मेदारी hai. I will be there to inspire you. If not me, one of the other faculty. Tomorrow there is a wonderful pediatric review of the past AIMS question bank by Dr. Gopati Srinivas, excellent teacher. So 6 to 7:30 we have a discussion. 7:30 to 8 we have a quiz before we say goodbye, tata. And you need to download the UMedico app, and you have the video library, etc. First timers who have come today, please give a call to the helpline number. They will give you a throwaway price just for about 5,000 bucks. you get a video library access on the UMedico app along with the mock tests and discussions. So please don't forget to call the helpline and pay for the subscription on the UMedico. So myelin figures are the phospholipid precipitates is what you need to basically remember. Commandant is requiring a gynecological consultation. Definitely, we have got Dr. Uday Shri, Dr. Shilpa Reddy, excellent teachers. They will review it. We will get them. Yes, definitely. Now, Doctor, right. The next question, hypernatremia, what is accept about it? Question number 179, yes. Raju Mallela says, sir, add colors to the notes. In the courses, the notes are all the same slides which you are seeing here. So that's the reason, don't worry. Okay. Now, question number 179. Everyone says C. And Snowberwani says A. Central pontine myelinolysis, come on doctor, is due to hyponatremia, not hyper. Why are you attracted to C? Oh, okay. Right. Now, Chopstick sign, where do you see this? Is the important question. That's right. Chopstick sign. And also remember on the UMedico app, under every slide, you can add your comment. And that comment becomes shared to everybody. And for every slide, you can add comments. Please don't forget. You can also be able to record your voice on the UMedico notes for every slide, and that helps other students also who are preparing. Make it interactive and upload a lot of things on the UMedico app, right? Yes. So it is a stimulation of the facial nerve lead to contraction of the muscles is a facial grimace. So thanks once more for a wonderful evening. See you all tomorrow evening at 5:30 p.m. 5 p.m. with the quiz. Thank you. Good night.